I'd like to go back to Dr. Boike for a moment. Dr. Shaglassian had talked about various types of imaging used to diagnose and stage prostate cancer, whether it be upfront at the time of diagnosis and staging, or for those with rising PSAs post-treatment with the concern of recurrent disease. Can you kind of walk us through your experience with PSMA PET imaging and where you think we're going and how theranostics might actually play a role and using this to treat prostate cancer?
Yeah, and I think you hit the nail on the head that this is a game changer, right? It's really changing the data that we know about, the trials that we've done in the past. We're having to interpret things through a new lens, which is this PSMA PET, where we're coming up with new ways to study it. But if you look at, a rising PSA after treatment, and you're getting a PSMA PET and you can see the disease, that may be something that's located right where the prostate was. And so it's confirming your treatment of radiation to that area if the patient had surgery. If patient had radiation and their PSMA PET is only positive in the prostate, we're starting to do more salvage options. So the urologists are doing cryotherapy or freezing the gland. There's some reirradiation options, but it helps get that PSA back down. And then you can delay things like hormonal therapy that are used to treat the whole body. In fact, as you've mentioned this term, oligometastatic disease, we're starting to see those patients with maybe 1 to 3 spots on PSMA PET, and we're starting to focally treat those spots and delay things like hormonal therapy that has a big effect in quality of life for these men. But as things become more advanced with PSMA PET, you're detecting multiple lesions. You have lots of options for treatment. We mentioned genetic testing and the role for PARP inhibitors, as we were talking, getting ready for this. You have the hormonal therapy agents, chemotherapy. And now, as you get after chemotherapy, there was a trial done called the VISION trial that was published in the New England Journal of Medicine. And this medication is getting more and more active. So you can do PSMA injections that are not only diagnostic, in the case of PSMA PET, but therapeutic. And what they do for that is where that PSMA medication sticks to the prostate cancer, for the PET agents or the imaging agents, it kind of glows like a light bulb, and we can see it on the scans. But where that then sticks, it delivers like a bowling ball when it's the therapeutic medication. Pluvicto is the FDA approved one right now from Novartis, but we have lots of trials coming. This is an extremely active area of research. And it's offering real hope for men after things like chemotherapy, where it's FDA approved. We're seeing responses in men that have had a significant amount of therapy where their PSA is declining over 50%, about 70% of the time. And they're having what they call exceptional responders, where the PSA is declining over 80%, about 20% of the time. So in these men who have gone through a lot of treatment, this is a very active, promising medication. And the questions for a study right now is, should we move it earlier? And can we do things like have a true pair where it's the same molecule, like in the case of Posluma, where you could maybe have an imaging agent like fluorine or F18 that glows like a light bulb, and then swap out that fluorine for something like lutetium or actinium, we're investigating a lot, and it bind to the same portion of the PSMA molecule or receptor. And so I think this is, again, a really exciting, lots to do, and I thank every day all of my patients for participating in research like this. I know we're quite active at MIU. We're active in my practice with these clinical trials.
Yeah, this is one time where a plug for clinical trials and research trials are really so important for patients to participate in, because it's the research that actually will give the improved care, not only for you, but for those that are to follow you. And prostate cancer being such a slow growing disease, and in most cases, men, well over 90% will die with it rather than from it. It makes it even more difficult in general to see the success rates of a lot of these clinical trials. Thank God that it is not a death sentence in the majority of cases, but more of a life sentence. And what Dr. Boike is actually talking about is taking a diagnostic imaging test, such as a PSMA PET scan, and making it a therapeutic treatment option as well, where it can actually exactly target the cells that need to be treated by using a radioactive compound to be mated to the diagnostic PSMA reagent. This is absolutely the biggest game changer in prostate cancer therapeutics. And the thought is, if we can do it sooner versus later, we would treat lower volume disease with lower toxicity and lower complications to the patients. And I think that's really what he's actually alluding to. And hopefully the NCCN guidelines will identify this, and the clinical trials will proceed, as we are already starting to take part in, to apply these newer technologies in theranostics that Dr. Boike is so well experienced in, that we can actually make these applications and see the fruits of this kind of treatment come true and lessen the toxicities of recurrent treatment of prostate cancer, so that rather than throwing, giant bowling balls at patients, we can actually target these with the very small focused areas and actually treat the disease without the complication.